Your heart could stop in the next 60 seconds if your potassium levels are too high. Today, we're diving deep into hyperkalemia, a critical topic for NEET PG aspirants that could literally mean life or death for your patients. We'll break down the stages, ECG changes, and emergency management that you absolutely must know. And with us is our electrolyte expert who's going to help us master this topic.
Thanks. And you know what's fascinating? Even as we speak, our bodies are constantly working to maintain potassium levels within an incredibly narrow range, typically between 3.5 to 5 millimoles per liter. When it goes above 5.2, we enter hyperkalemia territory.
That's such a tiny margin for error. Why is our body so picky about potassium levels?
Well, potassium is absolutely crucial for maintaining cellular function. Every single cell in our body has this thing called the sodium-potassium ATPase pump that maintains the membrane potential. When potassium levels get too high, it's like throwing a wrench into this delicate machinery.
So what happens when that machinery starts breaking down?
The consequences can be devastating. According to recent studies, the most serious manifestations occur when serum potassium hits 7 millimoles per liter or higher. We're talking muscle weakness, cardiac conduction abnormalities, and potentially fatal arrhythmias.
That's terrifying. How would we know if someone's heading into dangerous territory?
The ECG becomes our best friend here. The changes follow a pretty predictable pattern. It starts with tall, peaked T waves. That's your earliest warning sign.
Wait, so the T waves are like the canary in the coal mine?
Exactly. And here's something fascinating. There's this push-pull effect. While hyperkalemia pulls the T waves upward, hypokalemia pushes them down. It's like this electrocardiographic tug of war.
That's actually a really helpful way to think about it. What happens next in this ECG progression?
As potassium levels rise to around 6.5 to 7.5, the P waves start flattening or disappearing altogether, and the PR interval gets longer. It's like the heart's electrical system is gradually shutting down.
And I'm guessing it gets worse from there?
Oh yeah. Above 8.5, you get what we call a sine wave pattern. It's when the QRS complex gets so wide it merges with the T wave. At this point, you're literally watching the heart prepare for ventricular fibrillation or asystole.
You know what's wild? This reminds me of that scene in Austin Powers where Dr. Evil demands $1 million as ransom. It seems huge, but really isn't. Similarly, such a tiny change in potassium can have such massive consequences.
Ha! That's actually a brilliant analogy. And speaking of surprising things, here's something that often throws medical students off. ECG changes don't always perfectly correlate with potassium levels.
What do you mean?
Well, according to recent studies, patients can have relatively normal ECGs but still suffer sudden cardiac arrest from hyperkalemia. That's why we can't rely solely on ECG changes to guide treatment.
So how do we treat this condition? I imagine time is of the essence.
Absolutely. Treatment follows three main strategies. First, protect the heart with calcium, usually calcium gluconate or calcium chloride.
And that works immediately?
Yes, calcium acts within minutes to stabilize cardiac membranes. But it's just temporary. You need to actually lower the potassium levels.
How do we do that?
That's where the second strategy comes in, shifting potassium into cells. We use insulin with glucose and beta-2 agonists like albuterol. The standard dose is 10 units of regular insulin with 2 ampules of D50W.
But that just moves the potassium around, right? How do we actually get rid of it?
Exactly. That's where the third strategy comes in, elimination. We can use loop diuretics if the patient has good kidney function, or emergency dialysis in severe cases.
You know what's interesting? Our bodies actually have a circadian rhythm for handling potassium.
That's right. The kidney's ability to excrete potassium varies throughout the day, independent of what we eat. It's one reason why timing of medications that affect potassium can be important.
Speaking of medications, what are some common causes of hyperkalemia that NEET PG students should know?
The big ones are medications that affect the renin-angiotensin-aldosterone system, ACE inhibitors, ARBs, and potassium-sparing diuretics. Also, renal failure is a major cause.
Any other causes they should remember?
Yes, tissue breakdown conditions like rhabdomyolysis, tumor lysis syndrome, and severe trauma. Also, diabetic ketoacidosis can cause hyperkalemia through insulin deficiency.
Let's talk about some newer treatments. I've heard about potassium binders.
Yes, sodium zirconium cyclosilicate is a newer option. The standard dose is 10 grams 3 times daily. But remember, it's not a first-line emergency treatment.
Why not?
Because it works too slowly for emergency situations. In acute severe hyperkalemia, we need immediate interventions like calcium, insulin, and possibly dialysis.
What about prevention? How can we stop this from happening in the first place?
Prevention is crucial. It involves careful medication review, regular monitoring of potassium levels in high-risk patients, and adjusting diets when necessary.
And who are these high-risk patients?
Mainly patients with chronic kidney disease, heart failure, diabetes, and those on medications that affect potassium homeostasis. They need regular monitoring.
Let's break this down for our NEET PG aspirants. What are the absolute must-remember points?
First, know your ECG changes cold, peak T waves, flattened P waves, prolonged PR interval, and the dreaded sine wave pattern.
Got it. What else?
Second, remember the three-pronged treatment approach. Protect the heart with calcium, shift potassium into cells with insulin and beta agonists, and eliminate excess potassium.
And the third key point?
Know your causes, especially medications and conditions that impair potassium excretion. This often shows up in case-based questions.
Any common exam traps they should watch out for?
Yes, don't assume normal ECGs rule out severe hyperkalemia, and remember that treatment should be based on both potassium levels and clinical presentation.
What about pseudo-hyperkalemia? That seems like a potential exam topic.
Absolutely. It's when you get falsely elevated potassium readings, usually due to hemolysis during blood collection or prolonged tourniquet time.
How do you differentiate it from true hyperkalemia?
The key is that pseudo-hyperkalemia patients won't have ECG changes or symptoms. If you suspect it, always repeat the test with proper technique.
Let's talk about some specific numbers they should memorize for the exam.
Sure. Normal potassium is 3.55 LMol or L. Mild hyperkalemia is 5.5, 6.5, moderate is 6.5, 7.5, and severe is anything above 7.5 LMol or L.
And treatment doses?
Remember 10, 10, 10, 10 units of insulin, 10 belligreams of albuterol nebulized, and 10 grams of calcium gluconate. Makes it easy to remember in an emergency.
That's a great memory trick. Any final pearls of wisdom for our listeners?
Yes, hyperkalemia is one of those topics that connects multiple systems: cardiology, nephrology, endocrinology. Understanding it well can help you answer questions across different subjects.
And it's definitely high yield for NEET PG, right?
Absolutely. It's consistently tested because it's both common and potentially lethal. Plus, the treatment algorithm tests your emergency medicine knowledge.
Well, this has been incredibly informative. Any last words for our NEET PG aspirants?
Remember, when you see hyperkalemia in the exam or in real life, think: protect, shift, eliminate. Protect the heart, shift potassium into cells, and eliminate the excess. That framework will serve you well.
Perfect summary. And just like potassium levels need careful monitoring, so does your NEET PG preparation. Thanks for joining us on Copilot Podcasts, where we help you master one critical topic at a time.